So on Tuesday, March 5th, they are starting this conversation about menopause. And there's an editorial, and I'm going to talk you through this, but here's my opening comments. They argue that we don't need to treat menopause like a disease because it is a process, it is a time in our life, it is not a disease. Now, hear me out. If our US healthcare system wasn't so broken, I would jump on that theology train. Yes, it is a process, it is a time, it is a transition. It really is. But in our system, if you want to get care, you better have an ICD-10 code, which means you better have a disease process or nobody's going to treat you. If there isn't an ICD-10 code attached to what's wrong with you, you can't get it covered, nor will they care. Now, technically speaking, menopause is ovarian insufficiency. When your ovaries kick it, no more eggs going out, your hormones go in the toilet. It's a very complex process. But because women, when you go through menopause, depending on who you are, depending on your genetics, there's a host of problems that will happen. And so you could say that menopause is not a disease, but what happens during your menopause transition, you have a much higher likelihood of other disease processes. Your cholesterol might get crazy, your bone density goes crazy, you get sarcopenia. Let's not talk about insulin resistance, shall we? Oh, are you more likely to become pre-diabetic? What if you get diabetes? Do you see where I'm going here? I get that menopause is a transition, Lancet, but don't play me. We know that if I don't have an ICD-10 disease code, you're not going to give a shit about me. But let's go through this. Here we go. Menopause is an inevitable life stage for half the world's population, but experiences vary hugely. Some women have a few or no symptoms over the menopause transition, while others have severe symptoms that impair their quality of life and may be persistent. Many women feel unsupported as they transition to menopause. To better prepare and support women, the Lancet series on menopause argues for an approach that goes beyond specific treatments to empower women with high quality information. Yes, they should have high quality information, absolutely. Don't try to trick me, you're trying to woo me. High quality information, tools to support decision making, heck yeah. Read the book Estrogen Matters. We can mail that to all women. Yes, let's get behind that. Empathetic clinical care and workplace adjustments is needed. Targeted support is needed for groups who experience early menopause or treatment-induced menopause. Treatment-induced meaning they had a hysterectomy. Early menopause would be, 30s, 40. The average age of menopause is 51. Prior to 45 is early menopause. And for those at increased risk of mental health problems. Have you ever gone through menopause, Lancet? Have you? Because I'm pretty sure when you watch women go through menopause and perimenopause, the blues are real. But anyway, I digress. The authors recognize how gendered ageism may contribute to negative experiences on menopause and call for reduced stigma and greater recognition of the value and contribution of older women. We like to be called 40 plus. I don't need you to call my ladies older women. They are just in their best years. But let's look further at this editorial, okay? So here are some little breakdown articles. You can absolutely get this. So you can look at this. I'm just going to show you a snippet. The first one of this is an empowerment model for managing menopause. Yes, I am about empowering women. I want to manage menopause and get women the care they need. So in this first paper in the Lancet series on menopause, we argue for a new approach that goes beyond the treatment of specific symptoms to encompass a broad model to support women transitioning in this life stage using the model of empowerment. I know you want to empower me, but if you make it an ICD-10 code, my insurance would cover me. But just carrying on. And they talk about what empowerment is. And rather than focusing on menopause as an endocrine deficiency, rather than focusing on your ovarian insufficiency, which it is, we propose an empowerment model that recognizes factors that modify the experience in which the patient is an expert in their own condition and the healthcare worker supports the patient to become an equal and active partner in managing their own care. That is fine and dandy because I want every woman who has menopause on their radar to have knowledge, to have a conversation with their primary care doc. But there's not enough time in their well visit. And so for you to get coverage at the visit you would have with your doctor for menopause, you would have to make menopause an ICD-10 code to have this conversation so that the doctor and the patient could be equal active partners. And your insurance could also mail you a copy of Estrogen Matters so that you know. That would be good. Let's keep going. You can't see the title here, but this is the next one in the Lancet series, which is optimizing early menopause. And they go on to say that the average age of menopause is 50 to 51 in high income countries. So in the US, the average age of menopause is 51. However, let's start up here. Both early menopause and premature ovarian insufficiency can herald an increased risk of chronic disease, including osteoporosis and cardiovascular disease, right? So this is why I kind of feel like menopause needs maybe an ICD-10 code so that we can get the care we need so we don't get this. People who enter menopause at younger ages might also experience distress and feel less supported than those who reach menopause at an average age. Absolutely. We have witnessed many women getting gaslit by their doctors, but maybe I should just say their doctors didn't have the education to know about early menopause and they just send them away saying, no, you're just too young. Clinical practice guidelines are available for the diagnosis and management of premature ovarian insufficiency, but there is a gap in clinical guidance for early menopause. We know this, that's right. We argue that instead of distinct age thresholds being applied, yes, I agree with this, early menopause should be seen on a spectrum between premature ovarian insufficiency and menopause at the average age. This series paper presents evidence for the short-term and long-term consequences of early menopause. We offer a practical framework for clinicians to guide diagnosis and management of early menopause, which considers the nature and severity of symptoms, age, and medical history, and the individual's wishes and priorities to optimize their quality of life and short-term and long-term health. We conclude with recommendations of future research to address key gaps in the current evidence. Okay, I like this. That's 100% true. I like this segment. I've got this. I like it. The next one, promoting good mental health over the menopause transition. So the increased risk of major depressive disorder over the menopause transition appears predominantly in individuals with previous major depressive disorder. Okay. When the depression is bad and it is a major depressive disorder, like they describe. When I have talked to my psychiatrist friends, they agree with this, that you are unable to cope anymore, the wheels have come off. But that does not mean that women who are going through menopause don't feel blue. This is just one end of the spectrum. It's like the far, far, far side. There is lots of blues, like postpartum blues, like that general malaise. But let's keep going. On the basis of scarce data, we found no compelling evidence that risk of anxiety, bipolar, or psychosis is universally related over the menopause transition. This frustrates me. A paradigm shift is needed. We conclude that recommendations for the detection and treatment of depressive symptoms or major depressive disorder and the strategies to promote good mental health over the menopause transition while responsibly preparing and supporting those at risk. I don't love this one. I think if you look at other research, we have seen a generalized sadness. Estrogen helps us have motivation to do things. There is this malaise that does happen, and it is a period of rest. And yes, sometimes during the menopause transition, women do not get the psychiatric care that they need because maybe it is mislabeled as perimenopause. But what about the majority of other women who feel like the blue cloud follows them that aren't in a depressive episode? I'm not so sure about this particular one. Here's another one, Martha Hickey responding to the complexity of menopause. Menopause is a focus of Martha Hickey's clinical work and research, and not just a hormonal event, but the meaning for individuals in society and how this affects the experience. And they go on to say she takes a feminist perspective on menopause, which includes normalizing this life transition, which I do want us to normalize it, and challenging the prevalent idea that it is marked a period of physical and mental decline. We don't have to go batshit crazy, but I need you to know that batshit crazy could happen and that you're losing bone and muscle health. And I just, like Paul Revere, need you to know that the red coats are coming. Anyway, menopause challenges us to consider the role and social value of older women and the narrative that women's behavior in physical and mental health is powerfully regulated by their hormones. Let's unpack that. Women are cyclical beings, and we shouldn't throw older women out with the trash. They are a wealth of knowledge. I want to hear your thoughts. Go check out my other posts that talked about the editorial with Hickey. You're going to want to see.